Hi everyone, Dr. Bolz, thanks for being with us today. We get a lot of questions about different approaches to the hip for hip replacement, so I thought it'd be a great idea just to talk about this a little bit. And no questions are off limits, so feel free to ask anything that pops up. My wife, who's a teacher, always tells me I shouldn't lecture at people and everything should be engaging, so feel free to interrupt me. Got a couple toddlers at home, so I'm not immune to that. All right, so I'm going to start off with maybe some boring stuff for you guys, just a little bit of my background, and then generally I'll kind of breeze through a little bit of total hip replacement over the years, kind of where we came from and where we've gone to now, and then we'll talk a little bit about the different ways to approach the hip, and then focus a little bit more on the direct anterior approach, which is something I prefer to do if possible. So I'm a local kid. I was born at Providence in Southfield. So very fortunate to be able to practice in the same hospital and roll in the halls that I was around many decades ago. I was born to my mom and my dad, who actually both worked at the hospital there. My dad was an orthopedic surgeon for a long time, and my mom was an orthopedic PA. So there was very little hope for me to do anything else, and I couldn't escape that. My little sister was the one that did. She managed to be a family medicine doctor. So we're most proud of her in our family, except for her sports medicine fellowship that she did. So she's kind of come back to the dark side with us a little bit, but we're still proud of her regardless. Grew up in Nova on Walled Lake. I posted the best action shot I've had in my whole life and cropped it to make myself look a little bit better. But I grew up doing a lot of water sports, hockey, and that kind of thing. Trying to be as active as I can. So, for some people who ask me about my father, because he's practiced here for many, many years, so pretty well known around. He retired a few years ago and just doing normal retirement stuff now, like water skiing during the day or climbing mountains in Africa or snow skiing with my son. So it's he set the bar pretty high for retirement. I hope to live up to that when my time comes for it. Um, Living around here, I did go to Catholic Central for high school. I got the benefit of spending 1 year at our old school in Redford and then 3 years here in Novi. So I got the best of both worlds there. If you ask me which one I prefer the old school, but don't tell the administration there I said that. I was on the ski team there, and then I played hockey outside of school. So try to be as sporty as I could be. Then I went out to Michigan for my undergrad. I have to get a little bit of a plug to the team for winning the national championship this year. That's a picture of me with my partner, Dr. Custo. We managed to sneak away and get down there, despite what my wife might have wanted me to do. And then I went out to New York for medical school, just north of the city, but we managed to live in Manhattan for a couple of years, which was fun. My favorite thing to do if you ever get a chance to get out there is go to the theater in Central Park. It's my favorite place to go. And they just do a great job putting on performances, and they have a lot of plants in the audience, which caught me by surprise, but it's a really fun experience if you get a chance. I know everyone's into the Broadway shows, but I think this was a much cooler experience. Then I did my residency training back home at the DMC in Detroit. We got to live in Detroit a little bit because we are still itching for a little bit of city life. So if I had to pick one restaurant, that's my favorite one down there. It's in Corktown, and it's called Takoi. It's kind of a Southeast Asian place. Really good food, cool atmosphere, not too pricey. So if you get a chance to get down there, I highly recommend it. And then I finished my medical training in Canada, not too far, about 2 hours away from here in London, Ontario, which is a great center for joint replacements. They get lots of complex cases and revisions, and I got to learn from some of the best in the business there. One of the funny things about being in Canada, it's helpful to be a hockey player, but on the college campus we were on, instead of having, basketball courts surrounded by the tracks, they had hockey rinks surrounded by the tracks. So when we'd go play campus rec center, there was always the track team practicing around us, which was kind of a unique experience, I suppose. And then I always want to mention my support system kind of keeps me grounded and keeps me going. My wife, my son Quinn, there on the left, and then I have a newborn from November last year. Ben. And fun fact is they actually let me deliver him. So that was probably the scariest moment I've had in a long time, but it all worked out well. So enough about me. I just want to quickly glance over kind of total hip replacement, where we came from, and how we kind of arrived where we are now. It goes way back, I'd say, to Germany in the 1890s. It's first described. Dr. Gluck, in patients with tuberculosis, he tried to attempt hip replacements by replacing bony anatomy with ivory. There's no pictures or drawings of this, but it's been described. So we'll give him some credit. And then we shift back to the U.S. with Dr. Smith Peterson, who the direct anterior approach we're talking about today is actually named after. He had this concept of a glass mold replacement. So he would kind of make a glass model of the head of the femur, place it over there, and implant that into patients. Unfortunately, glass is pretty brittle, so these didn't tend to last very long and would break a lot. So when he was at the dentist one day, he got the idea of using this metal called Vitalium, and he would put that over the head of the femur, which you can see. I don't know if can you see my screen? He would put that over the top of the femur to try to replace that. He states he did it in about 500 people, and it went well. But I think our standards of well have evolved a lot over the last 100 years. So I don't do any of these for people. We have a few better tools at our disposal these days. And then we go to France, where they first started with femoral head replacements. They used these kind of acrylic stems that they put into the femurs of patients here. One issue is that they didn't have a way to fix these very well, so they tended to get loose, and that's what you see with all this differences in the bone here, and they tend to fail over time. So again, great temporary option, but wasn't a great long-term solution for patients. And then we come back to New York in the 50s, and they had more of a modern hip-looking design. A stem that comes down the femur, which is what they look like today, and this was attached to a femoral head. We have different options today to control this. And then the whole idea was that bone would grow between these holes in the metal to fix that stem into place, and that was their attempt to solve that issue that they'd had with previous models. And then later on, well, we came to this metal on metal, where they would do more than just the femur or the stem side, but they tried to resurface the socket as well. And this is a very scary looking thing. We do a little bit better job today, but it was the first attempt at it. So I give you all these kind of bizarre implants and instrumentation to show you how far we've come today. So we don't see many of these around that. And then really the modern hip replacement began in about the 60s back in England. We credit Dr. Charnley as kind of the father of total hip replacement. He had a stem that's cemented into place. He had plastic or polyethylene, which we still use today, that he cemented in place on the cup side, and then had this metal and plastic, which tended to have pretty good wear properties. And we've kind of grown and adopted from that today. So there's a few of these around that I've seen throughout training, and we've really just expanded upon what he did back in England. So, what's kind of changed from the 60s to today? A bunch of, great things that we find useful. The first thing is we have what I call modularity. So instead of that stem being kind of attached or welded to the femoral head, we have different options. So we can change the length if we want, different size heads based on stability. And it gives the surgeon a lot of tools in the operating room to really customize these to the patient and their anatomy, rather than having to use cement or rely on maybe prayer to hold these implants in place. We've developed great textures on the surface of these implants. A lot of them are actually 3D printed, and they're kind of a micro mesh type of implant, so the bone can grow into them, and it holds them very, very solidly. So these really rarely come loose, less than 0.5% of the time. So we've come a long way with that. And then we have different bearing surfaces. People always ask how long these last, and that's something that we've been attempting to solve over the years. we started on that metal on plastic that Dr. Charlie used, and we found that it did wear after about 10 years or so. So we went to metal on metal, but we found that there was some metal debris with that, even though the surfaces are harder. And then we moved to ceramic on ceramic, which is an excellent material, but the problem was they would squeak. And even though they'd have no pain, people don't like when everybody turns their head when they walk in the room because the hip was squeaking. So now the construct we use is a ceramic on this plastic. We have new plastics after 2002, and they show very little signs of wear at 20 years. So, we're optimistic that they'll last 30, 40 years and hopefully the lifetime of most patients. We just don't have any data on that yet to say. But, we rarely revise the modern hip for wearing out, so to speak, which is kind of an excellent thing for surgeons and patients. And then one of the newer things, I know we're probably not supposed to say specific companies because all companies have a robot, but I didn't want to litter the slide with lots of them. But we have robotic navigation now that we can use for knee replacements and hip replacements. And that just allows us to be a little bit more precise with our placement of our implants so that we can get things exactly where we are and there's no surprises and know what we're doing. So is it necessary? No. If someone has one without it, that's fine. It just adds another layer of precision if we need it or for complex or difficult cases. And then the last thing I'll talk about is approaches. So different ways to get to the hip to do the same job, and if there's any differences between them and what we prefer. So I'll just talk pretty briefly about how to get to the hip through the different places, and then we'll talk about the anterior hip the most. So when we're talking about a hip replacement, I know it's a little bit of a busy slide, but we're looking for basically clinical outcomes. So we want people to do well short term and be able to rehab rapidly and recover rapidly and get them back to their activities. And then obviously long-term outcomes are important. So are there any differences between them and who will ultimately achieve the best possible long-term result, especially as these are done in younger and younger people. So that's ultimately what we're looking for. We also want it to be a safe and reproducible surgical technique. So we want to minimize complications. We want to have excellent component positioning. And then we want to make sure if there's any issues that we can easily extend them and manage it in the rare case that happens. So things that we worry about things like infection. We worry about things like hip dislocations, which are rare after hip replacement, but can happen. And then we worry about any intraoperative complications like bleeding, injury to muscles and nerves, or any intraoperative fractures that can happen. So while these are rare events, they can be significant. So we want to minimize that as much as possible. So I know these are, again, busy slides, but this is kind of a cross section as if kind of the scan shot me like this. And the other one is from the side, just showing the hip with all the different muscles around. You can see in the back here where the gluteus muscles are, and in the front there's a bunch of muscles and some nerves up there. But essentially what we're trying to do is get to this area so we can remove the femoral head and neck and put in the implants that we need. So with the lateral approach, or more of a historic approach, we go through the side, and we actually have to split these gluteal muscles to get down to where we are. So one of the issues with that and things people worry about the most is the repair of that. So the advantage of the lateral technique is it's reproducible. It's very easy for us to do that. It has excellent exposure of both the femur and the pelvis to fix the head of the femur and the socket. You can easily extend it in case of issues or revision surgery. It decreases your dislocation rate compared to the posterior approach. And when you think about dislocations, essentially there's always a chance that the head can slip outside of the socket, especially when you've made an incision or injured some tissues around there. So any approach that in surgery we dislocate the hip through the front has a lower dislocation rate than through the back, just because of the activities you do in daily life. If if we have to go through the back, we weaken those tissues a little bit. So it's things like bending down or crossing your legs over that puts the hip at a little bit of risk. Now with modern techniques, that's lower. It's less than 2% of the time that happens, but it can be worrisome for some patients and surgeons too. And then another advantage is it tolerates obesity. So it allows tissues to fall to the side and lets us be able to get to do our job. The disadvantages, like I spoke about, we have to kind of split the abductor muscles. So a lot of the outcome depends on that healing, and it does quite reliably. But some patients can have a limp, even if it's painless, for up to 6 months. And then, it can be difficult to get some intraoperative imaging if we want x-rays or things because we position the patient on the side. And the posterior approach, which is, traditionally the most common, we make an incision kind of in line with those gluteal muscles. And then this is kind of the path that we take through that MRI scan. Sorry, I know it's a little bit tough visually to understand these. We haven't done thousands of them. But this is what it looks like when we get deep. There's a bunch of muscles here in the way, and then underneath it, right where my cursor is where the head of the femur is. So we actually have to take these muscles off the bone and reattach them afterwards, which can lead to a little bit of weakness in that area or in the structures there. So the advantage of the posterior approach, again, it's pretty reproducible and simple approach to use. It gives you excellent exposure everywhere you want. We can easily extend it in case of issues. It spares those abductor muscles, so you don't have to rely on their healing for limp or things. Again, it's very tolerant of obesity because you lay the patient on the side. Disadvantages, you have to repair the rotators at the end, and anytime you take something down and put it back, it's never going to be the same as it was initially. The dislocation rate is a little bit increased, especially in patients who have a history of hip dysplasia or spinal pathology. Although, again, with new implants and our understanding of these, this is becoming less and less of a difference between these two. Again, because they're on the side, imaging can be difficult. And then one disadvantage for patients is that usually for the first 6 weeks, surgeons put them on hip precautions, which limits their bending or how aggressive they're able to rehab. Then I put a picture of this because sometimes it makes more sense to go through the back if you have to take away a lot of hardware or things like that from somebody here who had a history of a bad pelvis fracture. And then I want to talk a little bit, kind of the meat of the talk today is about the direct anterior approach and why is this new? Is this the cure? Is there anything we should worry about when we're talking about this? So this goes back to what we talked about earlier with Dr. Smith-Peterson in the 30s. He did his training at Harvard and didn't like all the muscle dividing and splitting techniques that they had to use to approach the hip. So he began to do simpler procedures through this approach that's named after him. And this is kind of the path we take. We go through here. We go between the muscles rather than through the muscles, and it gets us right down onto the hip joint here. So this has been around for a long time, but Dr. Mata, who now has a clinic out in Vail, popularized this approach really starting in 2005, and it's taken off. So the question is, how often is it being done, and why now in comparison to the last 100 years? So this is the American Association of Hip and Knee Surgeons. This is just showing the different approaches here on the side and what percentage of joint replacement surgeons are using what. And I know it's a busy slide, but what I want you to focus on is in 2009, only 12% of surgeons were employing the direct anterior approach. You go to 2020 and 45%. So quite a dramatic difference there. And it's probably due to new instrumentation as well as better training on it as people come through residency and their fellowships. A couple things that help us, we have the development of this table. Exposing the femur for the stem side is really the challenging part of the approach. And a table like this that all the hospitals in the area that we use have makes this job much easier to do and minimizes the complications. We also have the development of new hip stems that are curved with curved instrumentations that allow us to access that femur, which again is the challenging part of this approach. So I won't show you all the pictures here, but this is what it looks like when the patient's positioned on the table. They're not on the back, they're on their side. And if you have any friends that have had this approach done, it's usually right on the outside of their thigh, a few centimeter incision, kind of right over there. So, what we do is kind of get down to the level of the muscle. We get through a little bit of the soft tissue, and we find the plane between the muscles, just like this, without having to cut or split them. And then we're down to the level of the we call the capsule, or that's the thick tissue surrounding the hip joint itself. One of the advantages of the direct anterior approach is that because their patients are positioned on their back, it's very easy to use X-ray intraoperatively. So this is us kind of resurfacing a socket, and it lets me put this in the exact position that I want and confirm it at the time of surgery. It also lets me put in, this is an example of putting in that socket or shell, and it lets me make sure that the angles in terms of the tilt and how open it is are in the exact position I want, with no guesswork. And on the postoperative X-rays, always look exactly how I got intraoperatively and what I'd expect it to look like. And this allows me to take a look at the stem too and make sure that I'm very satisfied with how everything was placed. So, I guess the question people always ask is, what are the benefits of this approach versus the other ones? Now, I would say it's a little bit more minimally invasive. It's a small incision on the lateral side of the thigh. We truly spare the muscles. So we go between the tensor fascia and the sartorius as the top layer. Then we go through these gluteus medius and the rectus femoris as we get deeper. So these are all supplied by different nerves. So we're not going in between one different nerve. So there's less chance of we call it denervation or injury to the nerves supplying muscles or things like that. It's easy intraoperative imaging, again, for my implant placement. And then one thing patients also worry about is leg length. And I can measure the leg length using this approach intraoperatively and make sure it's exactly where I want it to be, again, with minimal surprises post-operative. And this is just an example of how I check that. Here's our cup in place, and here's a piece of metal that I have holding over the hip from both sides. I line it up to the bottom of the pelvis here, and then I make sure that this little bump, called the lesser tuberosity, crosses this line in about the same position at both sides. So there I can be very confident that the leg lengths are consistent and are both quite equal. So in terms of your recovery, what's beneficial to this? Now, it showed that patients have decreased hospital stays, or they have decreased kind of failure to launch, so to speak. So we call a failure to launch when patients are planned to go home the same day and aren't able to for a wide variety of reasons. So this happens less often in this approach. There's a decreased dislocation rate compared to the posterior approach, especially in patients with spinal pathology. It's about 0.5% versus 2%. And hip precautions, especially those posterior precautions such as bending, are not typically necessary with the anterior approach, which allows patients to be a little bit more aggressive with physical therapy and getting back to the things they like to do. Now, various studies have shown that decreased pain and improve outcome scores from the 1 to 6 week window. So again, as you're initially rehabbing, it can be a little bit easier. I wouldn't necessarily call it easy, but easier than a different approach. And then studies have shown some decreased laboratory values for muscle damage or inflammation, but it's really hard to translate this into how much it matters clinically, but it's been shown in the lab at least. And then for therapy, it's been pretty extensively studied, and people will debate it on both sides of the aisle, but it shows that people are able to get rid of their gait aids, such as walkers or canes, a little bit faster. At 2 weeks, people are able to walk or take a few more steps. The unlimited walking marker is a little bit improved at 6 weeks compared to other approaches. And then some therapeutic markers such as the 50-meter walk time or single-leg stance seem to be improved with the direct anterior approach. Patients also seem to be able to have more normal stair climbing at 6 weeks, rather than one foot and another foot, or altered gait that they might have after a surgery. And then it's a little bit easier to get to tasks such as putting on your socks and shoes, which is usually a concern with patients who have hip arthritis. An important thing to know is, even though I prefer this approach, Really functionally long term, there are no differences between the approach and how patients do, at the 6 month mark, 1 year mark, 2 year mark, or after that. The most important thing is that you pick a surgeon who's comfortable with the approach that they do and can deliver a really reproducible result. So I know everybody is very adamant about getting going early in the first 6 weeks, and I think that's great. But I think ultimately, long term, how you do is more important, and especially when seeking a surgeon who's going to do this for you. So that's an important thing to keep in mind, because a lot of people come and they're very concerned that they're going to have one approach versus the other, but really, patients all do quite well with this. And then, are there any red flags or issues, or who shouldn't have this? You know, equipment constraints can be an issue. What implants you have available, or the tables or staffing. At the hospitals we operate at, it's not typically an issue, and it's becoming less and less of an issue, I'd say, nationwide. There is a learning curve associated with a direct anterior approach. 50 to 100 cases, people say, but that again is decreasing in terms of the training that people get in residency and fellowship training. So the operative times and complications decrease significantly after that. One thing that we worry about a little bit is numbness over the lateral aspect of the thigh, and that can come up by irritating one of the nerves there. So it can be irritating to patients if they can't feel their phone buzz in their pocket. About 50% of people have this transiently, but it tends to improve pretty quickly, and it doesn't affect any muscle or function after there. And then there's always been a question of, going through the front near the groin area, are there increased wound complications or things? And this is very controversial back and forth in the literature, but it seems to be very, very close, with a lot of studies showing no difference between the two, and some studies showing a little bit increased risk with the direct anterior approach. So you kind of have to have the trade-offs between approaches in terms of what you're looking for. And then, who's the ideal candidate? I think it's reasonable for everybody to have an evaluation for this if this is something they're interested in and want. While there are some red flags and things available, it doesn't mean it can't be done. Certain radiographs or x-rays can make it a little bit more challenging for us to do. It might increase the rates of us having to do something extensile, but it doesn't mean that people aren't a candidate for a direct anterior hip replacement. Things that make it more challenging for us are patients who have higher BMIs with this approach can be challenging, or a belly that kind of hangs over the incision site. Hip and knee flexion contractures, so people who have some stiffness with the hip in the front or the knee in the back, can make it a little more challenging to expose the hip, but that doesn't rule them out for it. And then these are more pelvic specific things that people have no control over, or if they have a wide pelvis, where it makes it more difficult to access the femur here. If the neck of the femur is short, so that means we have to pull it away from the pelvis a little bit more, or if it's angled down instead of this kind of normal alignment there, are all things. I've got a bunch of pictures showing it that can make things a little bit more challenging for us, but it doesn't rule it out being done. So I always like to, when deciding an approach with a patient, go through the x-rays, explain why I think one way or the other would be beneficial, go over the pros and cons, and then kind of develop a plan together. So I know it's a lot of information. Hopefully I didn't dumb it down too much or bore you. But I'm happy to answer any questions that you guys have and go from there. Thanks for joining us. So I'd say recovery differences between posterior and anterior. A lot of it is patient dependent, and depends on how bad their hip is preoperatively. The studies show in the first 6 weeks, people tend to have a little bit less pain with a direct anterior approach. But again, a lot of it's patient dependent. But in my experience, they do seem to recover a little bit faster with the direct anterior. I don't have data from my patients to study that, but that's what the kind of the national research studies have shown. I'm a big believer in risk modification. There's certain things that we can't control. Whether we have kidney issues or heart issues or liver issues, it's important to follow up with the doctor and make sure that everything's under control and medically optimized as best as we can. I think smoking is a big issue. Smoking doubles your risk of wound complications. So I advise everybody to quit smoking before they have it, because any kind of infection can be a huge deal. Diabetes is one thing that needs to be managed appropriately and make sure their A1C is a little bit low. But I think more so being active, stretching, and trying to keep the joint moving as much as possible, even though it's painful, lends itself to a lot more flexibility in the tissues and a lot better rehab. That, and especially depending on the pain medication people are on, to try to stay away from opioids or stronger narcotics, because it can be really challenging to control their pain afterwards, because people have built up a tolerance to it, and that can interfere with rehab and recovery. So typically, no matter what approach you have. I mean, we always caution patients if something feels off to limit certain activities, especially if the posterior approach, such as deep bending or things. Any kind of very aggressive contact sports can put you at risk for certain things. But I think the whole goal of these operations is to get back to doing the things that you want to do. With certain activities, there's always an element of risk, but I don't really believe in limiting people. These are mechanical devices, so I don't have lots of people who have these done that are going and running marathons and seeing things. It seems to me that the more you use it, the more you're going to wear these things out, but they have pretty good wear properties, and I think it's important to get people back to doing the things they do. So I tend not to restrict people after that, probably 6 to 12 week window after things have healed. Let them gradually get back to doing